Welcome. In this session, we'll be discussing the principles of optical coherence tomography angiography or OCTA and describe the findings on OCTA in a normal eye. We'll be describing the abnormal findings on OCTA in different retinal and choroidal diseases when we discuss those disease entities separately. OCTA is a proven non-invasive tool to study retinal and choroidal circulation. This photograph shows an OCTA image from a normal eye. OCTA imaging is based on motion contrast, and this is important to remember. During OCTA imaging, successive B-scan OCT images are taken along the same scan lines over time. And this is unlike standard OCT where a single B-scan is generated for each scan line. So in this diagram, these lines represent OCT scan lines along which OCT B-scans are taken repeatedly over time, and the locations where tissues move generate a change in the nature of the OCT signal between successive OCT B-scan images. So in this diagram, these are the three blood vessels which are scanned by this B-scan plane, and the OCT signal reflected by these blood vessels change over time as red blood cells move through these blood vessels, and an OCTA signal is generated from each location where there is a change in the B-scan signal reflected from these locations. This changing OCT signal from a location in motion is called decorrelation signal or OCTA signal. So an OCT signal from a reflecting tissue carries information regarding the depth and reflectivity of the tissue, and OCTA signal from a tissue carries information regarding the depth and the temporal change in the property of the reflected OCT signal from that tissue. So OCTA detects and analyzes this change in the nature of the reflected OCT signal from each location and shows locations with change in the nature of the reflected OCT signal in successive OCT B-scan images, such as blood vessels with flowing RBCs as bright areas, and locations with no change in the nature of the reflected OCT signal in successive B-scan images over time, such as the neural retinal tissue as dark areas, and this is very important to remember. So in the OCTA image, the bright areas represent locations where there is a temporal change in the character of the reflected OCT signal and does not represent the reflectivity of the tissue as standard OCT does. And this is very basic to the understanding of OCTA. By integrating all OCT B-scans generated from the imaged portion of the retina at any one moment, successive OCT volume scans from that portion are generated at definite time intervals over time. And we have discussed how OCT volume scans are generated at a particular moment in the previous session on OCT. From these successive OCT volume scans, a volume of OCTA data is generated which shows the changing areas as bright and non-changing areas as dark, as represented by this figure. And the OCTA data then can be displayed as in-phase images with which we are more familiar, as shown in this photograph, and which require segmentation of the data, as we will discuss next, or as cross-sectional images as shown here in this photograph as overlays of OCTA signals as red dots on a standard OCT B-scan. So in-phase images are generated by segmenting the volume OCTA data, and this diagram represents the segmentation of the OCTA volume data with the segmentation zones represented by the yellow, green and pink rectangular cuboids. So this diagram shows the result of segmentation along this yellow rectangular cuboid which contains the image of this blood vessel, and thus the in-phase image generated from this segmentation contains the image of that blood vessel. Similarly, these two diagrams show the result of segmentation along the green rectangular cuboid which contains the image of this blood vessel, and the pink rectangular cuboid which contains the image of this blood vessel respectively, and the images of these blood vessels are thus generated on the corresponding in-phase images. Different OCT machines use different segmentation algorithms and so the results of segmentation by one particular machine may not be directly comparable to the results of segmentation by another machine. And the property of the reflected OCT signal, whose change is recorded as an octa signal, can be either change in the phase of that signal or intensity of the signal, or both. Machines based on phase variation detection are more sensitive to motion and so can be affected by bulk eye movements, and machines based on intensity variation detection are less sensitive to motion and may not be able to detect slow blood flow. And this is the subclassification of the various octa technologies based on phase variation detection, intensity variation detection, and both phase and intensity variation detection. We may note here that Zeiss Angioplex and Heidelberg Spectralis, which are the common octa machines used, are based on both phase and intensity variation detection. The octa image is grayscale and the intensity of the octa signal varies with variation of blood flow velocity. And it has been seen that octa signal intensity saturates quickly with respect to the flow velocity. Current SD octa machines can detect motion signals with velocity between 0.3 millimeters per second and 3.3 millimeters per second. And when the velocity of blood flow is above or below this range, octa cannot detect the motion, and locations with blood flow velocity in these ranges appear dark on the octa images and can be interpreted erroneously as being non-perfused. These erroneous non-perfused areas are also called signal voids, which we will discuss further along with the other artifacts of octa. And the interval between two successive scans at the same location, which is usually 3 to 4 milliseconds, is important. So octa with shorter interscan intervals may not be able to detect blood vessels with low flow velocity, and octa with longer interscan intervals may miss RBCs flowing rapidly through blood vessels and is more prone to motion artifacts. Because of the quick saturation of sensitivity of octa signal with respect to blood flow velocity, efficiency of routine octa analysis for quantitative assessment of blood flow velocity is limited. Even with the available high OCT scanning speeds, the need for closely spaced scan lines and multiple scans through each scan line limits the view in octa to 15 mm by 15 mm area. So octa is usually used to visualize the vascular network in the macula and the pedipapillary area. This photograph represents the octa image of the normal radial pedipapillary capillary network, and this photograph represents the octa image of the normal pedifoveal capillary network. And the axial and lateral resolutions of octa imaging are the same as that of the OCT technology used. Threshold masking is a feature available in octa machines by which octa machines ignore structures such as vitreous, which have a low OCT signal but a comparatively high octa signal because of its motion, to reduce noise in the octa image. So now we come to qualitative and quantitative octa analysis of a normal eye. Qualitatively, octa images can be displayed in several ways, as two-dimensional in-phase images, two-dimensional cross-sectional images, and as volume rendered images. As we have mentioned, in two-dimensional in-phase images, as shown here in this photograph, the volume of octa data can be segmented in layers, and blood vessels in various layers of the retina can be displayed on in-phase images of the segmented layers. And for each column in a particular segment, either the average octa signal in that column or the maximal octa signal in that column can be represented or displayed in the corresponding pixel of the in-phase image of that segment. And by two-dimensional segmentation, in-phase images of superficial and deep retinal capillary plexuses, the radial pedipapillary plexus, and the choriocapillaries can be generated. And as we have discussed, in two-dimensional cross-sectional octa imaging, the octa signals are overlaid in the conventional B-scan image, with the octa signals being represented by red dots. And in these two-dimensional cross-sectional images, the flow information can be correlated with structural information, and two-dimensional cross-sectional images avoid segmentation error of In-phase imaging of different layers of the retina. Volume rendering of volume OCTA data avoids segmentation error but is not usually done as it is computationally sensitive, consuming a lot of computer memory. The OCTA software gives display options regarding the area of the macula to be displayed, which may vary from 2 by 2 mm to 8 by 8 mm on a standard OCTA machine. The depth of segmentation for in-phase imaging to individually study the superficial retinal vascular plexus, the deep retinal vascular plexus, the avascular outer retina and the choriocapillaries in addition to other layers, or to display a single image showing blood vessels in all layers of the retina and the choroid with different pseudocolors used for blood vessels in different layers. So we'll first see OCTA images from a normal eye before we go on to discuss the normal OCTA findings. So in a standard OCTA report, we'll find the area of display mentioned, the in-phase OCTA image, the in-phase OCT image, and a cross-sectional B-scan which shows the two segmentation lines from which the in-phase images are generated. And first checking these segmentation lines is very important, as we will discuss subsequently. So this is the OCTA image of the superficial retina, showing the superficial retinal capillary plexus along with larger vessels which are branches and sub-branches of the central retinal artery and vein. This is an in-phase OCTA image of the retina segmented at the level of the deep retinal capillary plexus. This is an OCTA image of the retina segmented at the level of outer retina, which is avascular and so appears dark. This is an in-phase OCTA image generated by segmentation at the level of choriocapillaries. This is the single in-phase OCTA image showing blood vessels in all layers of the retina and the choriocapillaries, and so we do not find any segmentation lines in the OCT scan. The superficial vessels are marked in red, the deeper vessels are marked in green, and blue represents the avascular outer retina. The retina can also be segmented at other levels, and this is the segmentation for the vitreoretinal interface. This is the segmentation for RPE and RPE fit. RPE fit representing the Bruch's membrane. This is the sub-RPE segmentation. This is a composite of the outer retina and the choriocapillaries as shown by the segmentation lines, and this is an in-phase image of the choroid as shown by the segmentation lines. In the peripapillary region, only two plexuses can be identified, which from anterior to posterior are the nerve fiber layer capillary plexus and the superficial retinal capillary plexus. And in the perifoveal region, three plexuses can be identified, which from anterior to posterior are the superficial retinal capillary plexus, the intermediate retinal capillary plexus, and the deep retinal capillary plexus. So the nerve fiber layer capillary plexus is not found in the perifoveal region, and the deeper retinal capillary plexuses are not found in the peripapillary region. The nerve fiber layer capillary plexus, as shown here in this peripapillary OCTA image, has large radial capillaries oriented parallel to the axons of the ganglion cells. The superficial vascular complex containing the superficial retinal capillary plexus appears as an evenly distributed plexus of large and small vessels branching centripetally, that is towards the center, and the nature of branching is said to be fractal, with the branching pattern at every level mirroring the branching pattern in the level above and below, and the vessels have a continuous linear shape with homogeneous walls and appears like a spider's net terminating centrally in a capillary ring around the foveal avascular zone. The vessels of the intermediate and the deep retinal capillary plexuses, as shown here in this photograph, have more complex minute interconnections, with the vessels arranged in lobules around the fovea without directional preference in branching, as seen in the superficial vascular complex. Choriocapillaries imaging is difficult with OCTA, and the choriocapillaries, as shown here in this OCTA image, appears as a lobular and granular sheet, and it appears granular because of white dots representing capillary flow through the choriocapillaries channels, with intervening dark areas representing intercapillary spaces or flow deficits. And large choroidal vessel imaging is even poorer and appear as silhouettes which are often dark in appearance. And among the quantitative metrics, OCTA is not useful in measuring blood flow velocity as we have discussed because of quick saturation of the OCTA signal intensity with varying blood flow velocity. But there are several quantitative metrics describing the blood flow distribution which can be measured on the OCTA, and these include perfusion density, which is the number of white pixels divided by the total number of pixels in each ETDRS segment of the macula. And this photograph shows the perfusion density calculated as a percentage in each of these sectors. The vessel length density is the total length of perfused vasculature divided by the total number of pixels in each of the ETDRS sectors, measured in millimeters per square millimeters. And other quantitative parameters which can be measured on the OCTA are vessel diameter index, fractal dimension, size of foveal avascular zone, and choriocapillaris density. Choriocapillaris density measurement is performed by recording flow deficit areas between OCTA signals originating from the choriocapillaris, and it has been seen that flow deficit areas increase with age, severity of myopia, and stage of age-related macular degeneration. Scan patterns with smaller imaging areas have higher lateral resolution, giving higher vessel length density values. On the other hand, scan patterns with larger imaging areas have lower lateral resolution, leading to higher perfusion density values. And it must be remembered that with different OCTA machines using different analysis algorithms, the quantitative metrics differ significantly between the machines. But in a particular machine, the metrics have been found to be highly repeatable and reproducible when the imaging parameters remain the same. Artifacts which may potentially occur in OCTA images are very important to understand and interpret OCTA. Motion artifacts occur because OCTA takes time for image acquisition, as multiple B scans need to be taken from every location, and this increased time for image acquisition may generate decorrelation signals called motion artifacts due to bulk movement of the eye during image acquisition from movement of the eye, head or the body, and movement of large particles in collections of fluid inside the eye, such as lipoprotein particles in macular edema. And motion artifacts can appear as vessel discontinuities and white or dark vertical or horizontal straight lines. Motion artifacts can also arise from stationary non-vascular retinal tissue due to Z-axis micromotion perpendicular to the retinal surface associated with pulsatile blood flow. Motion artifacts can be controlled by eye tracking and motion correction software, but with severe eye movements, motion correction software can itself generate motion artifacts, and these are of several types. Example images of each can be found on the internet. The second major form of artifacts are the projection artifact, which occurs when incident light undergoes phase variation upon striking red blood cells in a superficial vessel, as we have discussed, and is partially transmitted to the deeper layers and partially reflected back towards the machine. And this phase change light transmitted to the deeper layers may be reflected by a hyper-reflective structure in a deeper layer back to the machine, with the change of phase remaining the same. So the phase change light reflected from the deeper structure generates the same decorrelation signal as the light reflected from the red blood cells from the superficial vessel. So in our original example, in addition to the image of the actual vessel, in the in-phase image generated from the third segmentation block, we also find a mirror image of part of the actual image of a vessel, which is located in the in-phase image generated from the second segmentation block, and this is called the projection artifact. So projection artifacts appear as mirror image duplication in a deeper segmentation level of a vessel actually imaged in a superficial segmentation level. So here in an in-phase image along the deep capillary plexus, we find mirror images of larger retinal vessels projected from the superficial vascular complex, and these projections occur more from hyper-reflective structures like drusems, hard exudates and pigments, and they are more prominent in avascular areas such as outer retina and retinal pigment epithelium, where we do not expect to get an OCTA signal. as well as in deep capillary plexus as we find here. And projection artifacts from outer retina and retinal pigment epithelium need to be carefully differentiated from pathologic entities which generate true OCTA signals such as choroidal neovascularization. And projection artifacts appear as decorrelation tails in OCTA signal overlays on B-scan OCT, which appear as red vertical lines as seen here in this photograph. Projection artifacts can also be corrected with software, and in one method superficial in-face image is segmentally subtracted from deeper in-face images, but this may produce dark vessel artifacts as seen here in this photograph and areas of partial loss of true vasculature in the deeper in-face image. The other method of correcting projection artifacts is projection resolved OCTA or PR OCTA, which analyzes A-scans and removes the weaker projected signal from the deeper layer and retains the stronger true OCTA signal from the superficial layer. And in contrast to segmental subtraction method, PR OCTA method does not generate dark vessel artifacts. Segmentation artifacts occur because segmentation by an OCTA machine is based on OCT of a normal eye with good image quality. So in eyes with retinal and choroidal pathologies, segmentation errors are likely to happen. So in this diagram we see that a localized choroidal elevation elevates the outer retina, and the attempt by the machine to segment the avascular outer retina has failed. And part of the choriocapillaries has been erroneously included in this failed attempt to segment the avascular outer retina. So the in-face image of the outer retina generated from this failed attempt will display OCTA signals from this included area of choriocapillaries and will not appear completely dark as it should. So such an erroneous in-face image may generate the false impression of neovascularization in the outer retina, and manual segmentation can correct errors due to these kind of segmentation artifacts. So in this situation, the segmentation lines can be shifted manually to their appropriate location with respect to the displaced outer retina. Shadow artifacts refer to attenuation of true OCTA signal from a deeper structure due to a superficial hyperreflective structure, and a shadow is created posterior to the superficial hyperreflective structure. And in an abnormal dark zone on an OCTA in-face image, it is not possible to distinguish between slow velocity of blood flow and complete lack of blood flow, and these abnormal dark zones are called signal voids. Being a mode of angiography, OCTA should be compared with other angiography techniques, particularly the dye-based techniques. In contrast to fluorescein angiography, OCTA has the following features. It is a three-dimensional imaging technique with better resolution and can image the deep capillary plexus and the radial pedipapillary capillary plexus, which are not imaged by fluorescein angiography. In contrast to fluorescein angiography, OCTA is non-invasive, which is a very important consideration for patients with dye allergies, poor intravenous access, and in pregnant and breastfeeding patients. OCTA has faster image acquisition times in comparison to fluorescein angiography, and there is no blurring of details which may occur from leakage of contrast in fluorescein angiography. On the other hand, OCTA has a limited field of view and cannot demonstrate arteriovenous transit, leakage, pooling and staining, as it is not a dye-based angiography technique, and this is very important to remember that OCTA cannot demonstrate leakage in neovascularization. But OCTA may enable us to detect functional perifoveal capillaries in eyes with proliferative retinopathy, where excessive dye leakage may obscure the visibility of these perifoveal capillaries. OCTA can also determine impaired perfusion in radial pedipapillary capillary plexus. So this is an OCTA image of the normal radial pedipapillary capillary plexus, and this is an OCTA image of the radial pedipapillary capillary plexus in a glaucoma patient, where we find localized loss of these capillaries in the inferotemporal quadrant. And in comparison with indocyanine green angiography, OCTA is considered to be inferior in the detection of choroidal neovascularization because, as we have discussed, OCTA signals pass through retinal pigment epithelium poorly, more so with spectral domain OCTA machines as compared to swept source OCTA machines. and wide field OCTA is not as readily available as wide field fluorescein angiography and wide field indocyanine green angiography. So to interpret an abnormal OCTA, we have to follow a sequence. We survey all automated segments and attempt to detect any areas of abnormality. Then we should check the segmentation lines generating the abnormal in-phase images. And if automated in-phase segmentation lines appear to be erroneous, manual segmentation should be used as we have discussed. Then we rule out artifacts, following which we check the location of the abnormality and determine the nature of the abnormality in the vascular structure and its flow pattern, for which we may need to correlate with B-scan OCT with OCTA overlay and cross-refer with other imaging modalities such as fluorescein angiography and indocyanine green angiography. The key applications of OCTA is detection of impaired perfusion and detection of macular neovascularization. In comparison with fluorescein angiography, OCTA can detect areas with impaired perfusion much earlier and may display a larger area of impaired perfusion as compared to fluorescein angiography. Being non-invasive, OCTA can be frequently repeated and with its higher resolution is more suitable for detecting and monitoring progression of areas with impaired perfusion in patients with retinal vascular defects such as those with diabetic retinopathy and retinal venous occlusions. And as we have discussed, OCTA can identify impaired perfusion in radial pedipapillary capillary plexus in glaucoma patients, and the extent of impaired perfusion in radial pedipapillary capillary plexus has been shown to correlate with severity of glaucoma. And the other application of OCTA is detection of choroidal or macular neovascularization. OCTA images type 2 or subretinal and type 3 or intraretinal neovascularization well, but imaging of type 1 or subretinal pigment epithelium neovascularization is less efficacious with OCTA. To recap the salient points, optical coherence tomography angiography or OCTA is a non-invasive diagnostic modality based on optical coherence tomography to analyze retinal and choroidal vasculature. OCTA is based on motion contrast and works by analyzing the change in either phase or intensity or both in the reflected light as compared to the light entering the eye from its scanned location over time. This change in reflected light occurs only from locations where tissues move, such as flowing RBCs in blood vessels, but does not occur from locations where tissues remain stationary, such as the neural retinal tissue. Locations where reflected light changes in nature are shown as bright areas on the OCTA display, and locations where reflected light does not change in nature are displayed as dark areas. From the volume OCTA data, the machine can segment the retina and choroid in several layers and display in-phase images of each segmented layer separately. Layers which are commonly analyzed are the superficial vascular complex, the radial pedipapillary capillary plexus, the deep retinal capillary plexus, the avascular outer retina, and the choriocapillaries. Each layer has its own typical normal appearance. The OCTA display also shows the in-phase OCT image from the respective segmented layer and a cross-sectional OCT B-scan which shows the two lines used for the respective segmentation. And on this OCT B-scan, overlay of OCTA signals can also be displayed as red dots. Quantitative measurements which can be taken by OCTA include parameters which show the distribution of blood vessels, but OCTA cannot reliably determine velocity of blood flow. Since segmentation and quantitation algorithms differ between machines, the OCTA reports generated by different machines may not be directly comparable. Artifacts may occur during OCTA imaging, which may lead to erroneous interpretation of the OCTA report. These include motion artifact, projection artifact, segmentation artifact, and shadow artifact, and signal voids. Softwares are available to correct many of these artifacts, but these softwares may generate artifacts themselves. In contrast to fluorescein angiography, OCTA is non-invasive, provides three-dimensional imaging, images deep capillary and radial pedipapillary capillary plexuses, allows faster image acquisition, and produces images with higher resolution. But unlike fluorescein angiography, OCTA cannot show leakage, pooling, staining, or arteriovenous transit of dye. In contrast to indocyanine green angiography, OCTA is said to be less efficacious in detecting choroidal neovascular membranes. Applications of OCTA include detection of reduced perfusion through different layers of capillaries, which it does at an earlier age and showing a greater area of involvement as compared to fluorescein angiography, and also detection of choroidal and macular neovascularization, particularly types 2 and 3. Thank you for listening.